Good afternoon, everybody, and welcome to Friday, the 16th of October, and the last day of the Coeliac Society's Gluten-Free Living Show for 2020. I'm sorry, it's atypical of these things when you start to have a good, decent webinar coming up. Somebody decides to start hammering nails into the house beside you. So that's the banging, and I will be turning off my mic in a minute so that Dr. Kennedy can take over and deliver his seminar for you all. Thank you all very much for tuning in this afternoon. Just wanted to let you know that this afternoon's slot with the Coeliac Society of Ireland has been sponsored by Safefood. We're delighted to have Safefood on board with us. And Dr. Kennedy is going to be talking today about COVID, the flu vaccine, and celiac disease. I just wanted to let you know as well that we will be giving away a couple of hampers on this, and we will be pulling those at random, and I'll announce them at the end of the session. There'll be some breaks in the session, and what we'll do then is we'll take some questions. But for now, I'm just going to hand you over to my friend and colleague in the Coeliac Society, Professor Nick Kennedy. Good afternoon, Nick. How are you?
Hi, Jill. I'm good, thank you. At least I don't have anybody banging nails in the walls near me.
Oh, that's good. Thank God for that.
I did get a text message to say that DPD was on its way to leave something, and I hope they're not going to be here in the next hour.
How are things going for you, Nick, this year? I mean, it's been very different for everybody, but as an academic and as a lecturer in Trinity, how are things going there at the moment?
Well, it's very different from usual because I've had to do everything from home. I haven't been in my office since I cleared it out during the summer at the request of my departmental head because an administrator needed to use it. So I have no office, and I'm doing everything from home that I need to do for the college, including talking to students who are doing research with me and having meetings with my colleagues and lecturing online and doing assessments online, and it's all different.
Well, yes, but I do know you're going to ask for the help of the Coeliac Society in one of those research projects. What's that research project on, Nick?
Well, I'll reserve that till the end of my talk because I'll be telling everybody
suspense is killing me. Suspense is killing me. Well, on that note, I'll let you get cracking. So I'm going to put myself on mute in case the knocking starts again. But ladies and gentlemen, this afternoon, I'm going to hand you over now to our president, Professor Nick Kennedy.
Well, thank you again, Jill, and good afternoon, everybody who's watching. I was thinking that the best thing to do this year is to talk about the current issue, which is, as you all know, COVID. And I realize that a lot of people with long-term conditions like celiac disease are concerned if they have any special problems or special issues that they need to address. And I hope that I'll be able to go through some of the considerations. There aren't too many, by the way. So what I'm going to address in this talk are listed here. I'm going to say a bit about the virus and the COVID infection. I'll move on to say something about the influenza virus and a little bit of comparison between the flu and COVID, and run through the public health advice and any special considerations there might be for people with celiac disease in relation to that. So I'll break after the COVID section, and I'll break again after the flu section for questions if you have any. So as you may know, this is not a bacterium, it's a virus, so it can't replicate itself. It needs to use a host to replicate itself. That's the whole principle of viruses, sadly. So they invade your cells and they use your manufacturing mechanisms to produce more viruses, and then you excrete the viruses and pass them on to other people. So some of the viruses that are around are DNA viruses, which is the same kind of nucleic acid material we have in our cells. But the SARS-CoV-2 virus, which is the one that gives us COVID, is not. It's an RNA virus. And there are loads of different coronaviruses, and this is just one of them. So in this particular case, like many of the coronaviruses, the way people pass it on is through droplets that they exhale or that they generate when they're talking, shouting, singing, coughing, sneezing, etc. There's a whole literature on how far droplets go depending on their size and the environmental conditions. I won't go into that, but it's relevant to how much cleaning needs to be done. And the other issue is, of course, this virus doesn't just get into the lungs. It can get into other organs, and in fact, we can find it in feces, and it can be present in water because of sewage and all that stuff. So it's not just a respiratory virus, although it was initially thought it was. Unfortunately, we don't have a vaccine yet to protect us against this virus, although there's a big effort ongoing to try and produce that. And I'll say a little bit more about that in a few moments. I'm not going to go through all of this tree, but I just wanted to emphasize that the coronavirus family is broken up into lots of different subgroups. And the few that you see starred there with red stars are the ones that are dangerous for humans. There are some of these coronaviruses just affect animals. And yes, dogs and cats can get coronaviruses, but not necessarily have the same kind of manifestations as we do with our coronavirus CoV-2. So when we get this coronavirus infection, it's usually through droplets that are in our environment that we're breathing in, or on surfaces that we've handled, like door handles or counters or supermarket trolley handles or those kind of things. And then we have the viruses on our hands. And if we don't wash our hands or kill the virus off from our hands, the next time we touch our face, which we all do very regularly, we'll transfer the virus to our face and thereby likely into our mouth, nose, or eyes, and it can get into our bloodstream through that mechanism. So that's why, as you can imagine, it's very important to have a procedure to clean your hands regularly. Now, this particular coronavirus, SARS-CoV-2, which only started getting noticed in 2019, had a couple of precursors that were very similar in structure called MERS and SARS. And you may or may not have heard about those, but they are still around, but they're not causing as much disease as they were. They haven't been eradicated, put it that way. And it's not likely we'll ever eradicate this COVID-19 virus from our environment. It'll be around for a very long time. So we have to learn to adapt to that. And as you can see, at the top panel on the right there, COVID-19 symptoms, and it's sort of telling that this particular table doesn't put in it what I've put in green, reduction in sense of taste and smell, because at the very beginning in early parts of the year, the taste and smell abnormalities weren't really noticed as an issue and reported as a very common presenting problem with this virus, but it's now recognized that this strange loss of taste and smell, which a lot of people experience with this infection, is characteristic. And you don't get that so much in the flu, for instance, or in other coronaviruses that give you the common cold. And there are several of the coronaviruses which do give you the common cold. So, of course, there is effort also in Ireland to do research to figure out how we can deal with this viral pandemic. And I'm not going to go through all of the various projects that are funded in Ireland, but this one, for instance, which is being led by Paul Cotter and Teagasc, is to track the genetics of the virus as it goes through Ireland. And one of the things you can do when you're tracking a pandemic or an epidemic in seeing geographically where it's spreading and how it's spreading and how it changes with passage is to keep an eye on its genetics. And as people have this virus and pass it on, there are very slight changes in its RNA structure, which can tell you a little bit where it's going and where it's come from, if you have a big database of the virus nucleic acid. So just to go a little bit more on the genetics issue, it's sort of interesting to know that some people have different reaction to this virus causing COVID, depending on their genetic inheritance. And there's probably going to be a lot more found out about this as this research proceeds. But at the moment, and you can see this paper was only published yesterday in the New England Journal of Medicine, it's clear that people who have blood group A have an increased risk of getting a more severe version of COVID if they do get it. And those with blood group O have a decreased risk of having a more severe version. Now, obviously, nobody can change their blood group, but if people are going to be triaged or sorted into who needs to be looked out for more and kept a closer eye on for more progression to a severe case, then blood group is one of the things that we can measure relatively quickly and easily in a hospital. The other thing there, which is called a multi-gene locus on chromosome 3, And that is not something that's routinely measured in hospitals, and it's really only research that will figure this out. But this section of the chromosome 3 was a very strong signal of people who needed ventilation if they were admitted for treatment with COVID. So those who have an abnormality in that section of that chromosome appear to have a greater risk of progression to needing more ventilation, and appear to have a much more severe inflammatory reaction in their lungs. And the candidate genes in that section, which is changed, are listed there below. And I'm not going to go through what each one of those genes is involved in doing, but they are, the first 5 are involved in immune cell functions, T lymphocytes and dendritic cells. And the last one is to do with the connection between the receptor for this virus in our bodies, which is the ACE2 receptor, and the immune cells that react, which are the dendritic cells. So clearly it's to do with your immune system's ability to deal with the virus that is changed in people who have that multi-gene locus abnormality. So to move on to the kind of testing that we have to go through to find whether somebody who has suggestive symptoms has this infection, or whether contacts of people who have had this infection are positive yet, there are a number of tests that we can use. And maybe some of you have had these tests already, but the one that's most usually used for screening and for checking symptomatic people is the nasopharyngeal swab test, looking for the virus nucleic acids. And a swab is taken of the inside of the nose, the back of the throat, maybe even inside the mouth in some people, for instance, children. And then this is sent to the lab to analyze, and they multiply up the number of virus RNA molecules by using nucleic acid amplification, using polymerase chain reaction technology, PCR. And this means that if there's only a few viruses on that swab, 2 or 3 viruses, it will still be detected. So this test, the nucleic acid amplification test, is extremely sensitive. One could argue maybe a bit too sensitive, but it's definitely, if it's swabbed correctly and the swab is done correctly, which is also not always perfect, then the virus should be found. Another possibility is sequencing the RNA of the virus, which is what is done whenever you're trying to assess the genetic characteristics of the virus. And I talked to you about Paul Cotter's research. For instance, that would be doing RNA sequencing. This is not done as a screening test to see if you have or do not have COVID. This is just to characterize the particular virus that the person has who's had the swab test. The next possibility, and because you all have heard on the news and through chat shows that people are complaining that the tests are not being done fast enough, there aren't enough tests being done, etc. There are always efforts to try and expand the options. And one of the options that some of the testing companies have been quick to develop is a rapid antigen test, which means that you're not looking for the virus RNA, which is the thing that is the core of the virus. You're looking for the bits that are on the outside, the antigens on the outside of the virus. And that can be done fairly quickly, and it doesn't need a delaying step as the PCR does, because the polymerase chain reaction needs a bit of time. Rapid antigen testing can be done without a long step in the middle. It's not quite as sensitive, and it can't distinguish between whole viruses, which are infective, or virus bits, because the virus has been destroyed, but the bits are still hanging around. So it has drawbacks in determining whether somebody has active COVID. And this test, rapid antigen test, would probably be there for quite some time after the person's infection has been killed off. So that's not ideal. And then there are blood tests, and you may have heard about people wanting to have antibodies tested against the virus SARS-CoV-2. If you make antibodies against a virus or a bacterium or any other invading object into your body, or even your own components, like in celiac disease, the antibodies can be made in different ways. There's different classes of antibodies. But you will make an antibody against any infection, and it goes up a few days after the virus starts multiplying, and goes up, even after the virus has been killed off by the immune system, and then it falls down again over a period of weeks to months. So the antibody level on a once-off test doesn't tell you very much. If you have two blood tests, let's say 10 days apart, you can see whether the antibodies are going up or going down or staying the same. And that can give you a better idea of whether the infection is progressing or whether it's receding, or whether it's likely that you have had the infection in the past, but you just have some immune antibodies hanging around for a while to help you if you meet the virus again. So the antibodies are not used for screening. Some people have been trying to get antibodies checked, thinking that if they have no antibodies, they would be allowed to travel, for instance. And that's not a particularly valid assumption, and I'll say why in a moment. Another set of blood tests that can be done for research primarily is cellular immunity testing, where the researchers are looking for particularly T lymphocytes that are sensitized to the virus, and that can help. So whenever you get this this virus into your body, your immune system reacts against that in the way it would against any virus. It brings in the T lymphocytes and the B lymphocytes, and the T lymphocytes stimulate the other parts of the immune system to start fighting, and the B lymphocytes make antibodies. So some people who have really low antibody responses can still fight off this virus because their T cells bring in other parts of the immune system and they can clear the virus, but they don't ever have antibodies at any significant level. And that's one of the reasons why the serum antibody test is not 100% reliable for the purpose that people expect it to be useful for. And finally, I just wanted to say that home testing is another thing that some sections of the community have been shouting for, because of course it would be great to order a few home tests, do a finger prick blood test, put it on a gadget, and the gadget says, yes, you have antibodies against this virus, or no, you don't. But the home tests for that purpose are not recommended to use, and they're not available in Ireland anyway. The home testing that the HSE talks about is getting you a swab kit, and then you have to take your own swabs and send them in, or where a member of the testing team comes out to your home with the swabs, does the swab testing on you in your home, and then goes away again with the swabs for testing. So there's still work being done to try and improve testing, because the testing itself is a bit of a bottleneck in Ireland and in most countries. So this German company, Bosch, that you've probably heard of, has brought out a kit called Vivalytic, which is intended to be a point-of-care swab test. In other words, something that could be done, let's say, by a primary care center, a GP or a nurse, may be done by home visit, or could be done in an A&E department or somewhere like that. So a point-of-care swab test, which should give an answer within 2.5 hours. Now, this test is once again based on the need to multiply up the RNA, and it needs that 2.5 hours because of the PCR reaction time. But what's interesting about this particular test is it doesn't just look for the SARS-CoV-2 virus antibodies. It also looks for antibodies against 9 other respiratory viruses, or not the antibodies, the antigens, I beg your pardon. So the SARS-CoV-2 and the 9 other respiratory viruses can be detected by this test. So if somebody has a cold that has given them a fever, and they're coughing, and they have enough of the symptoms that it's hard to say whether they have a mild case of COVID or just a bad cold, this test will tell you whether that's going on or not. However, this test is not available and not in use in Ireland at present, but it might be something that will be used in future. The HSE, if you look at their website, has got lots of information about their policies and their procedures in dealing with this virus. So the swab that's used is put into the nose and the back of the throat, and that is then sent to a lab. And then you have to wait for the result. There are drive-through areas where people can get these swab tests done. They can sometimes be done in hospitals. It depends on the local area in the country where the nearest swab testing place might be. But usually the person who has the test has to find out what the result is, and it could be 3 days or more before the result is available. And I'm sure you've heard of people on the radio and on media saying that they were waiting for a week or 10 days or 14 days, which is really unsatisfactory when they could have this virus and they could be spreading it in that time. And the practical implication of that is that they should be self-isolating until they have their test result coming back negative. So as I mentioned a few minutes ago, the coronavirus antibody testing is looking for specific antibodies against the virus, not a general antibody reaction, but a specific antibody reaction. And if these antibodies are present, it could indicate that the individual has COVID now or has had COVID in the past. It doesn't mean that they're immune to the virus, because the threshold level of antibody that's required for immunity is not clear at the moment. We don't know how much antibody you need to have to prevent getting it. And it's probably not going to be very easy to determine that. So it's clear that having antibodies doesn't mean you're free and available and can't get it again. You could get it again. It doesn't tell you either if the person who gets this antibody test is infectious or not. If they have raised antibodies, they could still be infectious. And that's important, of course, in determining how they behave and whether it's safe for them to go out and infect other people, or whether they should self-isolate for longer. So if this test is done, for instance, with the intention of traveling on their plane, these antibodies don't tell you whether you're infectious or not. And it's not a very useful test. If it's negative, it doesn't mean you don't have the infection either. And that's a problem, because you could have an infection and you could be infectious, but the antibody levels are not very high. And I mentioned earlier that this is because if somebody has enough of a T-cell response, they can fight the infection, and they may seem quite well, but they don't have a very high antibody level. So you can see, if you look on the web, that there are places now offering these antibodies privately to people. So if you can't get it through the GP, which you will not be able to, and you want to have a test to see if you've had was that illness that you had 2 months ago, COVID, you might be able to get an antibody test done, but the result is not going to tell you very much. It's not going to tell you if you're immune, and it's not going to tell you if you're contagious. It might let you know that you must have been exposed to this virus somewhere before, but you don't know how long ago, based on the level of antibody. And actually, interestingly, it seems that people who have never been exposed to the SARS-CoV-2 virus can have cross-reactive antibodies that are picked up by this particular kind of test. And it may be that they've had one of the other coronaviruses within the last year or 2 years, and the virus antibodies against that come up as positive on this test. So it's not really a very good test to do, in fact, because it doesn't tell you very much, unless you're doing paired sampling. So I'm just going to say a little bit about the vaccine development issue. And we all know that there's everybody's holding their breath for a vaccine and hoping that it'll be available soon. And there are over 200 different vaccines under development, and a couple of them that were a lot of hope has been placed on. The trials that are in current operation have been stopped in a couple of countries because of illnesses that some of the people got when they were given the vaccine, and they're investigating that. The most recent one has been restarted in most countries, but not in the US. And that was only stopped 3 days ago, I think. But really, that's par for the course when you're developing vaccines. And out of the 200 different vaccine developments, one would hope there should be several that will be effective and safe, but not yet. And unfortunately, we don't have any timeline on that. We don't know when we're going to get a vaccine. We can hope that it'll be soon, but we don't know. We hope that it's going to be available within the next few months and preferably in spring, no longer than that, but we don't actually know. We don't know which vaccine is going to be available at that time that will work, and we don't know how it will need to be deployed. In an ideal situation, one vaccination, one shot would be best, because you can imagine that with the huge numbers of people who will need this vaccine, doubling the number of shots would mean huge increased purchase and cost of production, etc., etc. But the likelihood is that we probably will need to have a booster. And it's most likely that the people who will not respond wonderfully well to this vaccine will be the very people that are most likely to get COVID, the ones who are immunocompromised, very young, or the elderly, the people who are on medications that impair the immune response. These are the ones who actually need the vaccine to work most of all. And sadly, they're the ones in whom a vaccine is unlikely to take on the first attempt, and they may need several boosters to get immune with vaccination when it's available. So I saw this slide being used actually the day before yesterday by Luke O'Neill when he was giving a talk to the College of Physicians, and I happened to be listening to it. And I think it's hilarious because this is a slide that was generated by Barclays Investment Group. They're obviously putting money into the development of vaccines, and they're very, very keen on knowing when the vaccines are going to be available. And it's not just a question of them and their investments, it's a question of what will happen to the economies in the world. And they're trying to project how their business is going to change whenever the world opens up again after the vaccine is there. So you can see that the top three here, Moderna, Pfizer, and AstraZeneca, they in Barclays hope and expect that it'll be available at the end of this month, which is not the case. AstraZeneca's trial was the one that had to be stopped a few days ago because of problems. But there also had been a problem with the Moderna trial earlier. So we don't know how soon they're going to be ready, and we're not sure that they will be the right choice, depending on how problematic the trials are. The next wave of different types of vaccine they project will be available in the second quarter of next year, and then Merck's maybe the last quarter of next year. But at least if you look at the top 9 vaccines that are being tracked in the English-speaking world, it's likely that at least by the middle of next year we should have a vaccine. Well, I don't know which one, but all we can do is hope and wait. So I did mention a couple of times that it's possible to get this virus twice or more times, which is annoying, but it's not terribly surprising when you consider that we can get the common cold repeatedly, and this virus is in the same group as several of the viruses that cause the common cold. We just don't seem to be able to hold our immunity against some of these viruses very well. And the number of people who've been described in the medical literature who've had a second infection is still very low, only 5 or 6 people. But that's the tip of the iceberg, and it's quite likely that there'll be a minority of people who will be able to get this within the first year after getting it the first time. As I said before, people who have bad immunity are the ones who are not going to react as well to a vaccine, and the reality is that the people who have bad immune systems or suppressed immune systems because of medication or disease are the very ones who are likely to get a more severe case of COVID if they do get the virus, and if they recover from it, they're the very ones who are more likely to get it again sooner. So that's interesting that this particular case that was described most recently was a 25-year-old who's a young person. Usually the previous few that were described were older patients. So, of course, the concept that there is the possibility of getting this virus again twice or more times raises some quite searching questions. We don't know how common it is for people to get this again. We won't know for a while once we've observed and taken enough tests to check that it's the same virus and so on. We don't know how severe the reinfections are going to be. of the 5 or 6 that were described, some were quite severe and others were less severe. So we don't have a big enough sample of people to know what the trends are going to be in that respect. From the point of view of vaccination, it means that people who are immunocompromised will definitely need to be vaccinated multiple times, probably on a routine of every 6 months or every year or something, once the proper vaccine is found. But if you have people who randomly get sick multiple times, we can't necessarily predict who they are. And that 25-year-old man was not somebody who was immunocompromised, and it wouldn't necessarily have been expected that he would get a second infection so fast. So the vaccines, I'm not sure what it means for vaccines development, but it does mean that we'll probably need to be vaccinated more often if there's recurrent infections with different strains or different time frames. So to treat this virus once people get COVID, as you know, the majority of people have to stay at home and they're well enough, they don't feel great, but they don't get sick enough that they need to be admitted to hospital for supportive care. Some do, and if they do need to be admitted, most of them get discharged and are fine when they've recovered with a bit of support with oxygen and medications. And some will have to go into intensive care, and some of them will die. The supportive care, the level of supportive care depends on how sick the person is, and some people need artificial ventilation being put into an artificial coma, and they need IV medications of various types, antiviral, antibacterial, anti-inflammatory, and they may need anticoagulant treatment also. The people who are just having a bit of trouble breathing, not comfortable enough at home, but can be okay in hospital with oxygen from a mask, may only need that. They may be given some anticoagulant, but they're not necessarily going to need a huge amount of treatment. It was interesting that President Trump was in and out of hospital so quick and seems to be so fit and well afterwards, and they probably threw everything at him just to get him out onto his campaign trail quickly. But not everybody who goes into a hospital would get everything thrown at them, because they don't actually need it, mostly. So the kind of medications that would be used in treating somebody with a more severe level of COVID would be things that will help the body's defense system to work better. In other words, to boost their own immune system. And the obvious way to do that is to use antibodies that have been made by somebody who's recovered. So you get samples of blood from people who've recovered from the disease, you purify the antibodies in that, and you can give that to people who are not as able to fight with antibody production. So another possibility is to give the antiviral drug remdesivir, which also has some anti-inflammatory effects, but this was a bit of a sort of chance find. This drug was used against Ebola virus, but it also seems to have some antiviral activity against coronavirus, and that's helpful. It's running short in supply, unfortunately, so that it's not as quick to get now, because there needs to be a lot more of it made. It's being used so much all over the world. There just needs to be an upscaling of its production rate quite urgently. So another possibility, which also President Trump got, according to the news reports, was dexamethasone, which is quite a strong anti-inflammatory steroid hormone. So that reduces the so-called cytokine storm that is a problem with people who have more severe case of the COVID. It also increases the risk of further infection by other things. So dexamethasone has to be weaned off as soon as feasible. And because this particular virus has been shown to cause little clots in the smallest blood vessels, it's done this, showing evidence of that in the skin, in the gut lining, in the brain. One of the things that is done is to prevent those by giving heparin or another type of anticoagulant to try and prevent the coagulopathy caused by this virus, which is not caused by flu. It's not caused by the other coronaviruses. It's unusual, and people are working on it to try and figure out why it does that. There are lots of other experimental approaches, and Luke O'Neill, for instance, is working on one which has promise, but it hasn't been put to clinical trial yet. So besides the sort of molecular problems and immune problems that everybody thinks about in medicine, it has been clear that during this sort of lockdown and people's restricted movement, generally speaking, people in the population have found a trend to increasing their body weight. And there's been observed in multiple countries, but particularly Ireland and Scotland, that there's been a huge increase in alcohol sales during the lockdown period. And there has been an observation that there's increased cases of alcohol-related hepatitis. And that's worrying. And there are a number of reasons why it's worrying, but one of the things is that alcohol dampens down your immune system, and it will go against you fighting against any infection that you get, including COVID. I don't really want to go into all the psychosocial effects of stress and worry and problems with job losses and interpersonal difficulties with people spending so much time together at home and all of that. They've all arisen. So the last slide in this particular section before we break for questions, if you have any, is this one. And I am concerned, I guess, that autoimmune disease has, it's obviously, you know, that celiac disease is an autoimmune disease. You make antibodies against several autoantigens, including tissue transglutaminase. And some of the mechanism is not antibody mediated, it's cell mediated. And there's a specific type of T cell involvement in celiac disease also. And that's the case with all of the autoimmune diseases. In fact, this set of people, Japanese and others, did a review to try and figure out from the published information in the last 9 months or so whether there was any evidence that there was a difference in the risk of getting COVID or the clinical outcomes of COVID in people who do get COVID who have autoimmune diseases. And typically, they did not include celiac disease in their review. And their main focus seems to have been on rheumatic joint diseases. And in those people who are often on corticosteroids to reduce inflammation in their joints, they found that the people who are on particular monotherapies had a lower risk of severe COVID-19. And others who were on steroids had an increased risk of getting COVID-19 and an increased risk of a bad course through the infection. So what they found really was that the drugs that are used to control the autoimmune disease made the risk of the person to get COVID or get a more severe COVID was more important than the fact that they had the autoimmune disease per se. So that's encouraging in a way, but I think that that particular topic needs a bit more focus for celiac disease before we can really tell. So I'll just take a break at that slide, and if people want to ask questions, I don't know.
I have a few questions, Nick, that have come in. All right, yeah. So the first one is, if you've got symptoms of COVID-19, do you always have a temperature with it?
No. You may have a mild temperature or severe temperature. People are more concerned about getting a really high temperature because that tends to indicate that it's going to get worse quicker. But no, you can have no temperature.
Okay. I have diabetes and underactive thyroid, so a few autoimmunities. Am I more susceptible to contracting COVID-19?
In diabetes, yes. In underactive thyroid, it doesn't seem to have shown up yet as a risk. But in diabetes, the immune system is affected by the blood glucose levels, amongst other things. So if your diabetes is very well controlled and your blood glucose level is mostly within the normal range, it shouldn't have a huge impact on your risk. But if your blood glucose is not always well controlled, then it may have a greater risk. But as you know, in general, people with diabetes have an increased rate of infection, and this is an infection.
Do celiacs have lower T cells in general?
Not always, but some do, and that's a particular focus, and that's one of the reasons why I was concerned about this possibility that COVID might be more of a worry in people with the low T cell levels. As you may know, people with celiac disease can get a thing called hyposplenism, when your spleen doesn't work as well as it should, or it's too small.
Yeah.
And in people who have hyposplenism, it's possible theoretically that there would be an increased risk of this virus, because it has been noticed in the past that there's an increased risk of other viruses. But to date, this year, it has not been shown or published that any increase in risk has been found in people with celiac disease. That does not mean to say that it won't be found later, but so far we don't seem to see it.
Okay. Do you know how prevalent false negative, false positive COVID results are?
No, not off the top of my head. And there are so many factors that influence that. I don't want to go into it all, but one of the issues, for instance, it was found in a study, I think in the Mater Hospital, was that it depends on who does your swab, how accurate it is.
Okay.
So the training of the people who do the swabbing is fairly quick, and it is quite clear that that is one of the biggest reasons for a misleading result, is the efficacy of the swabbing process itself.
Okay.
So if you've got people doing swabbing, volunteers or people who've been redeployed from the army or the guards, or anybody who's doing these swabs would need proper training in it. And I'm not sure that they're all getting enough training to be totally confident that all of the swab tests are giving you the 100% accurate story.
Yeah, I saw that in the paper during the week as well there. I'm just trying to keep the questions here specifically to this section of the talk. What I will do is I will try and maybe leave a lot of these till the end of the talk, because I can see the time is ticking away. So Nick, I'm going to let you go on to the next section if that's all right.
Sure. Thank you. So the next bit is going to be very brief, because I'm not going to spend a lot of time talking about influenza, but you probably know that every year people are offered flu vaccines. And that's because we have recurrent waves of flu arriving in Ireland and spreading through our population. And people have been trying to compare, for instance, the impact of the flu pandemic. There were several flu pandemics. There was one in 1919. There was one in the late 1800s, Spanish flu. And it killed an awful lot of people in Ireland, that flu pandemic in the early 1900s. So people obviously think, pandemic, death, and COVID is doing the same thing. It's causing more deaths. And unfortunately, just because the coronavirus is doing the rounds at the moment this year, doesn't mean the flu isn't. And the flu will and is making its approach. And we do have to protect ourselves against it, just like we do every year. And the people who are at risk of flu have to get the virus protected against by getting a flu vaccine. At least we have a vaccine. The flu vaccine isn't perfect either, but it certainly makes a big impact on the likelihood of getting the flu or the severity of it if it isn't totally protected against. Now, there isn't as big a family of influenza viruses as there are coronaviruses, but there are two groups. There's type A and B. And the most usual one that we get is type A. And the one that's doing the rounds at the moment is the H1N1 type A RNA virus. Like coronaviruses, the flu is a RNA virus. And like the coronavirus, CoV-2, the main way we can get flu is by getting it through droplets. So actually, it seems from early observations that the number of people getting the flu this September, October seems to be less than last year. And that may well be because there are more people wearing masks and there are more people isolating and so on. And the measures that we're taking to try and reduce the spread of coronavirus have also probably done the same, reduce the spread of flu. And that's good. But the reality is it's still there waiting for us. And it's something we can prevent ourselves getting by being vaccinated. And yes, definitely, I would suggest everybody gets flu vaccine. So getting vaccinated against flu is particularly important because some people who get flu will get very sick and will need to be admitted to hospital. And that takes up time and beds in the hospitals, and it means more people with coronavirus who need hospital beds will be competing a little bit. And that's the nightmare scenario for the HSE, really. And the reality is that you can get away from getting the flu by having a vaccine. So there's no reason why you shouldn't have a vaccine. As you probably know, people with celiac disease are recommended to always get the flu vaccine because they're considered by the National Immunization Steering Group or Committee that they are more of a chance of being slightly immunocompromised because of not controlling their celiac disease properly and having poor immune responses because of that, or because they have hyposplenism, which is not as common as one would think, but anybody with celiac disease really should have the flu vaccine, especially this year. There isn't any evidence that getting vaccination against flu will prevent you or make it more likely for you to get COVID. It doesn't impact on it. Some people have been spreading a story about this around in different countries because there has been observation that some vaccinations actually do protect a bit against COVID, but flu vaccine isn't one of them, so it's not a consideration. As I mentioned before, people who are likely to get infection generally are the ones who have poorly functioning immune systems, and they are at increased risk of getting every infection, including flu, including the SARS-CoV-2 virus that gives us COVID. Getting one of these infections does not protect against the other one. So you could be recovering from COVID and get the flu, or you could be getting the flu and getting COVID at the same time. And obviously, if you do get both at the same time, that's a really big problem for your lungs. And it makes it much more likely that you'll end up in hospital, and you don't want that. So don't forget to get your flu vaccine. Also, because it's flu season now, and it's also time to get colds when people are exposed to kids who have been in school, and you know what it's like every autumn, people going to school, the kids come home with runny noses and colds and coughs. And it's not going to be any different this year. And then you've got a problem because you don't know whether you've got a cold, whether you've got the flu, or whether you've got COVID, or any of the combinations of those that you like to imagine. They all have common, they have symptoms in common. They're not all the same. You're much more likely to have a cold if you have a runny nose and a drip down the back of your nose and a sore throat. And you're familiar with getting a cold, everybody gets them. The flu tends to make you feel a bit worse than a cold does. It tends to be much more lung orientated, and you don't get the loss of taste and smell to the same extent at all as you do with COVID. Not everybody who gets COVID will lose their taste and smell, but if somebody gets a loss of taste and smell and they have cough and they've got a temperature, that's most likely to be COVID. So I suppose the best thing to do is to continue until this section comparing the two is finished before I stop again for a few questions if people want to ask. These are images of the two different viruses. They're actually very similar looking, aren't they? A lot of viruses do look the same sort of thing. They've got these spiky things coming out of a ball-shaped protein structure with the nucleic acids in the center. And these red colored on this particular image spikes on COVID-19 are called the S proteins. And they're the things that dock with the receptor ACE2, the angiotensin converting enzyme 2 receptor in our cells. So that's the docking spikes, if you like to call them that. So this is a fairly comprehensive looking table that was published in August in the Journal of American Medical Association to compare between seasonal flu and the SARS-CoV-2 virus infection. And you can see here that the main way people transmit this virus is by droplets. SARS-CoV-2 goes the extra mile because you can also get fecal oral transmission, but it's not as often the case, and it's not as important in terms of numbers of people as getting airborne droplet spread. the COVID is much more contagious than flu, really a lot more contagious. And once people get the infection, the issue is how soon are they going to spread it? The flu situation, people get infectious once they've started getting the symptoms. They already have the symptoms before they start being infectious, so they can stay at home and not walk around too much and get into other people's way because they don't feel well, so they'll stay at home. Whereas in the case of COVID, the people who get COVID are most infectious. The most infectious point is about 2 days before they begin to get the symptoms, which is really the problem we have, because people don't realize they have it and they're spreading it, and it's very infectious. And this is why people must use masks. If they're going to be going out, they feel fine, but they've had a contact with somebody who got COVID. They don't realize yet they have COVID. They may never realize they have COVID, but they're spreading the virus. The incubation period for flu is 1 to 4 days. It's the most usual is 2 days. And for the COVID virus, it's anything up to 2 weeks, which is why the 2 weeks period of self-isolation is promoted as the period needing self-isolation. So 5 days is more usual. It's the median, the most frequent number of people who are incubating the virus. The incubation period is around 5 to 7 days in most people, but that it could be anything up to 2 weeks. So as you can see, there are differences between the two, but this bit about infectivity and infection incubation period is especially important to realize in order to help to reduce the spread of this pandemic. So you can see the most common clinical manifestations here are quite similar, actually. Anosmia, which means reduced smell, and angustia, which is decreased taste, is also missing from that table, but it goes along with not being able to smell very well. And again, somewhat interestingly, COVID doesn't seem to get as symptomatic in kids. They do get it. They're just as likely to get it as adults, but they're much more likely not to have symptoms. And when they do get it, they're much less likely to have the cytokine storm that causes such really severe illness and death in adults. We don't know yet to what extent children spread this. It would be very surprising to me if they didn't, because they get it. And children generally do play a fairly big role in propagating other viruses, including the common cold, which can be due to a different coronavirus than the one causing COVID. If you look at the fatality rate, influenza is about 0.1% of fatalities. In COVID, it can be anything up to 3%, which is a lot more dangerous. So COVID is much more dangerous than flu. And whenever you have people like the president of the USA saying it's just it's like a flu, it is not like a flu. It affects more organs. It's a more dangerous virus, and it should be taken far more seriously than the flu. Something else which has become recently evident because of the increased chances of little clots forming in small blood vessels with COVID is the increased risk of stroke in people who get COVID over people who get flu. And flu does not cause the little clots, coronavirus does, and that's why there's an increased risk. So I guess we'll pause here, Jill.
Okay, well, I have a couple of questions coming in. I'll try and get through them fairly quickly. Is it worth boosting our immune systems with vitamin D, calcium and zinc coming into flu season?
I'll say a few things about that in the next section, actually.
Right, okay, that's fine. Does the pneumonia vaccine have any effect against COVID or the flu?
No.
Okay, that's that. I'm currently recovering from facial shingles. I have psoriasis as well as being a celiac and hypertension. Does the shingles virus impact on the risk factor of a poor outcome from the COVID-19 virus?
Difficult question to answer simply. I would say that having had shingles, your immune system has been challenged. and you are more at risk of getting an infection because you have had a fairly debilitating virus like shingles. So you need to be particularly careful and not expose yourself to people who have the virus, and behave like somebody who needs to be cocooned in a way. You need to shield yourself a bit more because you've just had a nasty episode of shingles, which takes quite a lot of work for the immune system to fight off.
I'm really sorry to hear about that from that member. Is the flu vaccine recommended for children? And this as well, is it okay to get the flu vaccine for children via nasal spray?
The nasal spray is the recommended way to give it to children. Yes, and yes, probably children should get the flu vaccine, yes.
And in particular for child celiac?
Yeah, I think that there is an age cutoff. I don't know what it is for kids. I need to refer to a GP for that.
Okay.
But yes, older children probably should, if they have celiac disease or any other condition like diabetes, for instance, they probably should get the flu vaccine.
Okay. If a child has Graves' disease and celiac disease, are they at higher risk? Should they be kept out of school?
I don't think they should be kept out of school, no. I mean, clearly, if they're sick, they should be kept out of school. Just because they have celiac disease, no. If the celiac disease is being well managed, you know, they should have the same risk level as any other child.
Okay.
Graves' disease shouldn't impact on it. There is an autoimmune process going on, but it's very localized to the thyroid, and it's not as big an issue.
Should every person with celiac disease get the pneumococcal vaccine as well?
Yes, and Haemophilus influenzae.
Okay. Does the flu jab weaken the immune system for other breathing infections?
I don't think that's the case. Maybe the first couple of days after the flu jab, your immune system might be a bit hyperactive, but I don't think it would weaken you to, you know, getting cold or anything else. No, you don't need to keep out of the way just because you've had a flu vaccine.
Okay, so that just to let people know who are listening on the call, the age for children's vaccine for flu is being offered by the HSE is from 2 to 12 years. So children who are aged between 2 and 12 years can get the flu vaccine with the HSE. Just going back very quickly here now.
Thank you for that, Rosemary.
Indeed. I have a daughter who's a celiac and carries an EpiPen for peanut allergies. I'm wondering, would this affect her immune system regarding COVID?
No, it shouldn't.
Okay.
A peanut allergy is IgE mediated primarily, and that's why you get the EpiPen to avoid, to treat anaphylactic reactions. Okay. But you're dealing with a very specific part of the immune system to do with allergy. And having allergies or anaphylaxis does not increase your risk of viral infection.
Okay. Would my risk be even higher for COVID-19 if when I get my celiac flares that I depend on an oral course of steroids over the week every now and then? Apparently this person is in the front line as well.
I would say yes. If you're getting steroids, your risk of getting COVID is increased.
Okay. If you get the flu jab, should you isolate for a few days? I work with children and have a family member that's high risk.
No, the flu doesn't give you the flu. The flu jab is not going to give somebody else the flu. No.
Right. Okay. Well, we've gone through a couple there now in relation to that session. Oh, hang on one second. Type A blood, clotting disorder, slow to clot and celiac disease. Is there an increased risk of getting COVID?
I'm not quite sure how those things are put together, but there shouldn't be any change in coagulation function because of celiac disease. There can be low platelet counts in some cases of celiac disease, which can be an autoimmune thing, or it can be due to bad nutritional state and insufficient production of platelets. That's not very common, but if people have a low platelet count, actually that would make it better for them if they got COVID, because they're less likely to get clots because their platelet count's low.
Okay.
But just something else here. I'm sorry to interrupt you,
okay.
Jill. Pauline asked something about, she's on methotrexate and Vimovo for rheumatoid arthritis.
Yes.
Methotrexate decreases all of your white blood cell numbers, and that does increase your risk of infection generally, And I would say, yes, it probably does increase your risk of COVID. Although that review that I pointed out during the talk was specifically focusing on the corticosteroid effect in rheumatoid arthritis. They didn't specifically comment on methotrexate, but I would expect, yes, methotrexate causes immunosuppression and therefore would increase your risks.
Okay. I have a celiac, underactive thyroid, and Hashimoto's and asthmatic. Would the flu vaccine increase my asthma risk?
No, but it would improve your health by avoiding flu. And if you're asthmatic, you're at higher risk of getting COVID. So you should definitely get the flu jab, and you should make sure that your pneumococcal vaccine and Haemophilus influenzae vaccine have been done recently enough to still be protecting you.
Okay. And finally, would taking a drug such as Solpadeine, which has codeine in it, for backache reduce immunity to COVID?
No.
Okay.
Solpadeine has paracetamol and codeine, neither of which have a negative impact on immune function.
Grant. Okay, Nick, I see it's 2 o'clock and we need to rattle on here, so I'll let you crack on there, okay?
Okay, thank you. So I just wanted to highlight again the public health advice that you're probably all sick and tired of looking at. You've seen this everywhere, haven't you? So this is the HSE public message. Wash your hands, cover your nose when you're coughing or sneezing, avoid touching your eyes, your nose, your mouth. Clean things that are likely to have been coughed or sneezed on or touched by people who haven't washed their hands. Don't shake hands. I know it's a bit antisocial and all that, but hugging, kissing and shaking hands increases your exposure to this horrible virus. So hand hygiene, just to show you, this is an article that was published only a couple of weeks ago on the 3rd of October from a group of Japanese people. And they did something interesting. They looked at the stability of this COVID virus, the SARS-CoV-2 virus and influenza A virus on human skin surfaces. And they wanted to determine how effective it was to use a sanitizer with 80% ethanol as a hand sanitizer. And essentially you can see the results, and the conclusions are that the SARS virus can survive for 9 hours on skin. And therefore, if you don't wash your hands, the viruses that you're in contact with from the door handles, supermarket trolleys, whatever else you've been touching, that other people have touched, that toilet handle, you know, whatever it is, the 9-hour survival, that's what it will. So you have to wash it off. And if you look at flu virus, the flu virus doesn't last anywhere near as long at all. And although it does last for what, 1.69 hours rather than 9. So regardless, it's very important to have proper hand hygiene. And interestingly, they said that both viruses were completely inactivated within 15 seconds by ethanol treatment at 80% weight by weight ethanol. So if you have a sanitizer, which is 80% or more ethanol, it will kill off the viruses in 15 seconds. So the next thing is, are you spreading it all the way around your hand properly, or are you just giving it a quick rub and forgetting to go in between your fingers and other places? So this diagram is sort of dramatic, but it shows you that the viruses move in and out of the airways. And there's a useful little video that if you have the chance to look at here, I'm not going to show it to you during this talk, I don't have time, but if you look at this video, it gives you an idea of the effect of different masks on preventing droplets moving away from your face, and different types of mask and different thicknesses of mask. And it's a very useful visual representation of how well or how badly particular face coverings work to help stop the spread of droplets. So wearing a mask, obviously you've probably looked at people around you wearing masks, and you can see lots of people with them hanging around underneath their chin, and they're probably thinking they don't need it because they're not in a shop at the moment. And there are others who go into the shop and they forget to pull their mask up. And then there are others who wear it underneath their nose. So if they sneeze or they're breathing out viruses because they've got a runny nose, for instance, then they will be spreading viruses. And then you see people who are wearing these one layer fashion masks, which don't actually stop the droplets getting out fully at all. And people cough away there merrily, but they don't realize that their little thin mask is not stopping very much. So the kind of mask and the way you wear it is important. And it's thought that you need at least 3 layers for the best effect. The CDC in the US recommend 2 layers, but in Europe, and the WHO have been recommending 3 layers. Now, if you consider the masks that you're using, there may be paper type masks, which are, the disposable ones that you can get. And they do have 3 masks if they're properly made. 3 layers in the mask, I should say. You look at the ones that you get sewn, not all of them have 3 layers. There's no point in having a layer in a mask that you can't breathe through. So a layer of something that's really difficult to breathe through should not be one of the 3 layers. Otherwise, people won't wear it. It'll be too difficult to breathe and talk through it. The other aspect, of course, is that if you use a reusable mask, it needs to be washed regularly. And again, people vary a lot in how they do that. There are specific recommendations on how your face mask should be washed, available on the CDC website, which are useful to look at. There's a temperature that it has to be washed above, etc. And some people don't, they use low temperature washes. That's not going to clear out the viruses that are caught in that mask. There's also, as you know, been discussion about face visors as alternatives to masks. And you can see on that photo, one person who doesn't like the idea of wearing a mask or has been given some dispensation because maybe they have asthma or something, not to wear a mask. And frankly, a light mask should be possible for anybody to wear without impeding their breathing. But I know some people dislike having their face covered, but a shield or a face visor is not going to be an adequate substitute. They do not stop the droplets being spread by that person. The purpose of the mask is to stop you infecting other people, primarily. It gives you some protection, but not as much as it gives other people. The face shield, again, is used in hospitals, for instance, when people are using full PPE because they use a mask and a shield over it. And the shield is supposed to stop people coughing and spitting stuff into their face, but it's not there to prevent their droplets spreading to the patient. The mask is supposed to do that. So wearing a shield alone is not enough. They should be used in conjunction with a mask. You often see these shields being used behind shop counters. Butchers often use them, for instance. And yes, it may protect the butcher from people shouting and spitting at them, but it's not going to prevent them spreading anything they have. The other thing is, if they do cough or sneeze, the droplets are going to be directed downwards. And if you're dealing with a butcher who has a cough or sneeze and they direct all their stuff downwards at their meat, that's not very reassuring for clients. And if these kind of visors are used by waitresses and other servers in food establishments, that's exactly the same problem. Standing, taking an order from somebody through a visor, when they're sitting down below you and you sneeze, you're not going to be protected as the client at all with that visor. So I'm going to move on to conclusions here. I'm not sure there's any point in opening questions for what's been standard advice, but I'll move on anyway, because I know that time's moving on. So my advice to you, really, the conclusions that I would draw from what I've read and said, is that you need to protect yourself. Avoid unnecessary exposure to other people. Avoid physical contact, which spreads this virus for the moment. Practice social distancing, and in this country we still use 2 meters as the correct social distance, although when masks are worn and other protective measures are taken, it may be reduced to 1.5 meters in some places, like colleges, for instance. And you should wash your hands often, and I've told you why, and this needs to be done properly, getting the soap into all the cracks and crevices, and at least 20 seconds of exposure for the soap to the virus. You should do that after going to the bathroom, before you eat, after blowing your nose, coughing or sneezing, and when you come back home after being out touching places that other people have touched. So if you can't get at soap and water, then use an alcohol-based hand sanitizer, and it should be preferably 80% alcohol to have a quick effect. You should try to avoid touching your face. It's a really difficult thing to avoid touching your face. People have to adjust their masks, for instance, and they're touching the mask, which could be contaminated by yourself. And if you then touch surfaces after touching your contaminated mask, somebody else will touch the surface you contaminated with your fingers that adjusted your mask. You need to wear a face covering when you're in an enclosed space with other people, and it may well be that in future weeks the possibility is that we'll be told or asked to wear face coverings even when we're outside in urban places. So in some countries they're asking people in cities to wear masks at all times when they're outside their own home. Not here yet, but who knows what could come. Do remember to clean the surfaces in your home that are touched by multiple people, door handles, toilet surfaces, etc. You can all identify the likely risk surfaces. To protect others from spreading viruses that you have to them, it's a similar type of measures as you do use to protect yourself, but you need to also to turn your head away from people when you cough or sneeze, cover your mouth or nose with your sleeve or your tissue, and dispose of the used tissue safely and quickly. Don't just leave them sitting somewhere that other people could touch them. Somebody asked about vitamin D. Well, yes, vitamin D deficiency has been linked to the severity of COVID in people who get COVID. And there have been a number of papers written on this subject, and this particular one that was published this month is a review of the evidence. And they were very clear in that review that vitamin D deficiency is a bad place to be if you're exposed to COVID. So if you look at this particular example of one of the papers they reviewed, these are people who, it was only 176 elderly people, elderly over the age of 60, tested for 25-hydroxyvitamin D in blood and tested for COVID-19. And they found that severe COVID affected people had much greater vitamin D deficiency. Even in our own country, you may have heard Roseanne Kenny, who has been the lead on the TILDA study, has shown that vitamin D deficiency in Ireland is a real issue. And we all know that we have low vitamin D between October and April every year because of low sun and often clouds between us and the sun. So it's really probably advisable for everybody in the population in Ireland to take vitamin D supplements during the winter months anyway, regardless of whether they have or don't have celiac disease or whether they have had any other infections. Just take vitamin D every day, and that should reduce the severity of COVID if you get it. And in fact, it's likely to boost your immunity to reduce your chances of getting COVID. Although that effect is not going to be huge, there is an effect. I also pointed to a YouTube clip there, which gives you a nice little sequence on the health benefits of sunlight. One of my, two of my colleagues, Dan McCartney and Declan Byrne. Declan Byrne is a consultant in James's, and Dan McCartney is a senior lecturer in dietetics in TU Dublin. And they published this in August, I think it was, and they're basically recommending, on the basis of their studies, that people should take 20 to 50 micrograms per day of vitamin D to enhance their resistance to COVID-19. Most people with celiac disease who are already taking a calcium and vitamin D supplement could be taking 20 micrograms per day if they're taking, for instance, 2 calci-chew a day. But if they're only taking 1, they would be getting 10 micrograms per day. And frankly, it's better to just take an additional vitamin D supplement to bring it up to somewhere in between there, 35, 40 micrograms per day for celiacs. The other issue that I mentioned already, I think, is that alcohol is an immunosuppressive effect. Well, it depends a bit on how much alcohol and what the timing is when you're testing the immune responsiveness. But the reality is that if people are drinking more every day or every week, they're going to be reducing their immune response. So the big question that everybody asks is there an increased risk for me if I have celiac disease of getting COVID or of having COVID more severely? And there really isn't a lot of evidence about this, but if you have uncomplicated celiac disease, you're on your gluten-free diet, you're taking your supplements, you're healthy, you don't have any greater risk of getting COVID or having a more severe case if you get COVID. In celiacs, there is this niggle about splenic hypofunction, which some studies claim is present in up to 40% of newly diagnosed celiacs. Other studies have contradicted that, and it's down to 2 to 3%. And it's just very difficult to tell, to be honest. But if there is a very definite splenic hypofunction and there's low white cell counts, then yes, that person is likely to be somewhat immunocompromised and they might have an increased risk. But there are no studies reported to date since this COVID pandemic to highlight that there has been a worse scenario for people with celiac disease. If you do have refractory celiac disease and you need to take steroids from time to time, then there could be an increased risk because of the steroids and the immunosuppressant medication. And it depends on how much immunosuppressant you're taking, how much self-isolation should be carried out. If this particular recommendation from the British Society of Gastroenterology recently was that if people are taking more than 20 milligrams or more of prednisolone, and they're only using prednisolone as an example, of course, there are other steroids which would have different threshold amounts. Dexamethasone would be less, for instance. But if you're taking 20 milligrams or more of prednisolone, then you should consider yourself to be at very high risk of getting COVID, and you should be cocooning. So the recommendations, to get to the final few slides, are to really observe public health measures to reduce the spread of COVID, ensure that you get the flu vaccine as soon as you can, and ensure that your other vaccines are up to date. Take vitamin D supplements. Remember that most people who get COVID are fine. They make a good recovery. They don't have long COVID. They don't have long-term effects. The vast majority. It's very difficult to know which people will get long COVID, and it's not yet very easy to know which people who get COVID will have a bad time of it. There is increasing research now to give the doctors a better view of which people need to have harder treatment given quicker. And actually the death rates in Ireland for COVID have improved. There are more people getting COVID, and knowing they have COVID, there are fewer people going to hospital with COVID than you'd expect for the numbers being picked up with the disease. And when they're in hospital, fewer are being admitted to ICU. And when they get into ICU, fewer are dying. So the figures are getting better over the last few months, and that's good. So we shouldn't be completely doom and gloom, but it is important not to help this pandemic spread as rapidly as it is now. It's important to remember that you may not have symptoms when you do have COVID. And it's also important to remember that there are people beginning to be found to have reinfections. We don't know how to prevent the reinfections other than having a virus vaccine, and we don't even know that if a vaccine is done, it will prevent reinfection in time. We just have to wait and see how things go. The second thing of recommendations here is to adhere carefully to your gluten-free diet to optimize your immune function, and do keep healthy, do exercise, don't allow yourself to gain weight, maintain a healthy body weight, take care of yourself, and if you're getting fed up and depressed and stressed, don't just bottle it up, try and talk to people about it, and there are services that you can get access to. And don't be tempted to hit the bottle. It's not good for your immune system, never mind your liver, your stomach, your heart, your brain, and practically every other part of you. There's a lot of myths going around, and I found this particular list of mythbusters available from the World Health Organization is quite interesting, eye-opening in a way. I hadn't really considered that some people were worried that mosquito bites would spread COVID, but that's a myth. So I just wanted to ask that you take part in a survey that you may get by email if you're a member of the society, and I have two students I had mentioned earlier, and Jill asked me to say what they were doing. This particular student, Neve, will be doing a survey of the society members to identify their perceptions of the current pandemic and their views about what's happened to impact on them in terms of the health services that they have needed or wanted to have during the pandemic. And we'll be comparing the results of that with an Italian study. And there are a number of additional questions in it which may help the society to improve our advocacy and to consider how better to offer dietetic services through the society. So if you do get this email, I would ask please that you do participate in it. We need your help. Thank you. The second student is not going to be in association with the society and is currently in week 4 or 5 of her review, and she's reviewing the evidence available in the literature about the potential for a link between gastrointestinal symptoms of COVID and up to 40% in some studies of people with COVID to get diarrhea during the first week of their symptoms. We don't know whether that has any bearing on whether they've had previous gastrointestinal disease like inflammatory bowel disease or celiac disease, and we don't know whether that is likely to trigger autoimmune reactions in the gut like inflammatory bowel disease or celiac disease. And she's going to do a search to find out what evidence there is to inform us of those kind of issues. There are some studies in animals that suggest that autoimmunity can be triggered by COVID in the gut in animals. And if that's the case in humans, we need to know about that. And that's what the second student will be doing. So I hope that answers your questions, Jill. And I would like to thank you for listening to this rambling talk that I gave, and to thank Safefood for sponsoring the society and allowing us to put on such a good set of activities during this week.
Thanks, Nick. That's great. There's a couple of questions. If you have a few minutes, we can just maybe rattle through them very quickly. Most available sanitizers are 70% ethanol. Is this effective enough?
It would be effective enough, but you'd need to use it for a bit longer than the 80%. So it may not be 15 seconds, it might be more, but yes, it would be enough.
Great stuff.
Things that go down to 20 or 30% probably wouldn't be.
Okay, right. So we're looking at 70% plus, and just keep rubbing it in the hands for a long time.
Well, no, I mean, you're talking about half a minute. It's not a
know.
long time.
Well, not a long, I'm not saying forever, but definitely make sure you scrub it in there. Is there one multivitamin alone you'd recommend for celiacs to get all of their vitamin requirements?
Unfortunately, there isn't any single multivitamin that I know that gives you enough vitamin D in one tablet.
Okay.
However, the one that I usually recommend is Centrum 55 plus or whatever it is, which has more of the B vitamins in it than the others.
Okay,
but it still doesn't have quite enough vitamin D in it, so you'd need to take that separately in addition.
No, vitamin D is so important. Yeah. Should asthmatics wear masks outdoors?
Well, I think that if they're in proximity with other people, perhaps. It depends on how bad the asthma is, frankly. I mean, if you have asthma and you're taking a preventer inhaler that has corticosteroids in it, like beclomethasone, or there are several. If you're taking the steroid preventer, you are at higher risk of getting viral infections.
Okay.
You have to remember that. If you're not using a steroid preventer, but you just use a bit of the Ventolin or Atrovent or something like that to make you feel less breathless when you get a bit of a wheeze, then that's not going to increase your risk of getting the virus, but the steroid inhaler would.
Okay. Can you overdose on vitamin D, Nick?
Yes, it's possible theoretically, but you need to take huge amounts of it.
Okay, so don't eat all the calci-chews at once.
Well, no, but if you do that, you'd probably get bunged up, so you couldn't do anything else.
I was diagnosed 9 weeks ago. I work in a creche and have had no vaccines yet. I'm 49 years old. Am I at risk of picking up something?
Well, I think that if you work with kids and you know yourself, I would definitely get a flu vaccine. Okay. Absolutely. Yeah, and you probably should get the other vaccines that are available to you, like the pneumococcus and Haemophilus influenzae. Unfortunately, the most common things that you would get in a creche, there is no vaccine for. the common cold doesn't have a vaccine. There's about, I don't know, hundreds of viruses that do that kind of a common cold thing. Some of them are adenovirus, some of coronaviruses. You can't get a vaccine for that.
Do we know how many celiacs have had COVID-19 and how sick they became?
Don't know.
No, it's because we've no celiac register,
No.
but the Coeliac Society is working on that as we speak. Are there any other factors apart from blood type that would account for the differing impacts of the virus on people, i.e. apart from obesity and age?
Yeah, well, the slide I said about the genetics and the segment that's altered in chromosome 3 is one of many others that could be there. So, I mean, I'm sure that in time, it may become evident more of why some people do much worse and some people get some of the particular complications. Some people seem to get a hypertensive reaction several months after having COVID. We don't know why. Some people get neurological manifestations due to inflammation in the brain. We don't know why. Some people seem to get little micro infarcts in the brain, and that's probably to do with the coagulopathy. We don't know exactly why everybody who gets that now. Maybe it's some endothelial factor. We just don't know. So there's a range of possible complications, and we just have to try and prevent them happening in as best we can at the moment with the medications available. But if you looked at any infection under a microscope, you'd probably find that some people do better and some people do worse, and we don't really know why. So I'm not being complacent about it. I'm just saying we don't actually know why exactly some people are more likely to get, inflammation in different parts of their body, and some people get hypertension and some people get cardiac arrhythmias and so forth. We don't know exactly. I noticed that Rosemary has also said here that Patrick Halford takes D and C every day. And yes, vitamin C has been given in large doses by some people in ICU. There's very little scientific evidence that vitamin C helps with this particular virus any better than it helps with anything. But I know that proponents of vitamin supplements will take vitamin supplements. There is evidence for vitamin D, definitely.
Okay, great stuff. Finally, Nick, we mentioned calci-chew a lot with the Coeliac Society, and that's just to do with the fact that celiacs don't get enough calcium as well as the vitamin D.
There are other products, and I don't want to be promoting that one over others. There are many products that have calcium and vitamin D combined in them. Most of them now have 10 micrograms of vitamin D per tablet, but they used to have 5. Many of them now have 10. And I see that Dimp Narayan says Sona has 10 micrograms per tablet. That's good.
But you need 20.
But you need 20 at least.
Okay. And
you don't need necessarily to twice as many of the other stuff.
Last question, because we really have to let you go. We've taken up too much of your time. Did you say children are at the same risk of getting and spreading COVID as adults?
They seem to be at the same risk of getting it. I can't say that they're the same risk of spreading it, because there is not enough evidence of that being looked for. But if you speculate, if there are children who get COVID and they're not symptomatic, they're likely to be spreading it. If you compare their risk of spreading it to an adult with asymptomatic COVID who's a spreader may not be in contact physically with as many people as a child would be, but I don't know for that. That's just speculation on my part.
Okay. Listen, Nick, thank you so much for your time today. We've really run over, but I do know that everybody who was everybody who was on the seminar really found it very interesting and very informative. There was a lot to take in that now, guys. So just to let you know that we have recorded this and it will be made available to everybody who registered for the show. It'll be made available to you later on this afternoon, on maybe definitely first thing on Monday. They'll also be available on our YouTube channel and through the Coeliac Society website. I'm going to grab something to eat now because I'm on again in half an hour when we have Mairead Finnegan of Roll It Pastry as our last seminar and last cookery demonstration of the week. Nick, my thanks again to you, and it is lovely to see you looking so well and healthy and COVID-free, thank God.
Cooped up in my little room.
So I'll talk to you again, and thank you again to everybody. Good afternoon and thanks a million. Take care. Bye-bye.
Cheerio.